It's a great privilege and honor to introduce our friend and colleague, Dr. Baban Azizzadeh, who is the chairman and director of the Center for Advanced Facial Plastic Surgery. He has longstanding interest in not just plastic surgery, but specifically facial nerve issues. So he's going to be here today to talk about management of post-facial paralysis and smile dysfunction. So thanks for joining us, Baban.
Thanks, Bill. I really, really appreciate it. I'm so honored. And this is an area that about 18 years ago, I walked into Bill's office. He didn't know who I was. A colleague introduced me to Bill. And he's like, who's this guy walking into my office right after fellowship, telling me that he really loves this facial reanimation. I've been really, really, he's mentored me, and we're really good friends, and I really appreciate it. And the entire house clinic group has been just really, really important for my own career development and personal development. So I appreciate your collaboration over the last 18 years. So I'm going to try to kind of, because I know there are some fellows, and I'm going to try to kind of go over a pretty comprehensive process of how I process and analyze patients who present with facial paralysis. The majority of this discussion is not on acute facial paralysis and its diagnosis and immediate management. And I would say that 99% of the information that I'm going to share with you are patients who present maybe 6 months, 9 months, in their process. So more of a long-term factors. The other thing that I want us to really consider with a lot of recent data is that I know we always have an arbitrary time period of 1 year, waiting 1 year before initiating facial reanimation, but several studies have shown that earlier intervention is really, really important. So we'll go through that. I have no relevant disclosure, and I'll try to go over the neuromuscular pathway that leads to an ideal smile, discuss the various types of facial paralysis, etiology of post-facial paralysis with synkinesis, surgical planning for various types of paralysis, and any novel reanimation techniques for facial synkinesis. So kind of like I simplify smile and facial expressions into really 3 parts. We have our brain, that's kind of the generator, signal generator. We have the facial nerve, which all of you guys know its course and what happens, that travels through the temporal bone in a circuitous route and comes out into the parotid gland at the stylomastoid foramen, splits into various branches. These branches go into various muscles. Some muscles get multiple branches, some branches go into various muscles. And it's very, very, the circuit is very, very important for us to be able to achieve an ideal smile. And today we're talking about ideal smile because that's our most important factor in expressing ourselves with loved ones, with colleagues, with friends, and so forth. And an ideal smile requires this neuromuscular pathway to be intact, to give us a spontaneous, natural, emotive. And a lot of times we're always focused on the corner of the mouth moving, but there are a lot of other factors that kind of show people that you have a normal smile. Symmetrical laugh lines, symmetrical dental show, both in the upper and lower teeth, symmetrical timing, and the cosmetic aspect of it is very, very important. when I was training, it was all about, okay, just let's get this face to move. And of course, that's important and, in giving power. But really, patients want to look better, feel better. They want to be able to go out and socialize. And it's all about their quality of life. That's important. Now, some of the key smile muscles, obviously, we all know about the zygomatic muscles and the levator muscles, but the depressor labia inferioris is also very important in giving us and allowing us to have a full denture smile. And many times when we're laughing out loud, it is this like showing of all the teeth that really comes out, and patients, uh, you know, are able to express themselves. Now, for me, the number one factor is really preservation or recreation of the neuromuscular pathway that will give us this ideal opportunity. And this is something that really, until I started doing some of these nerve ablative procedures, which I'll talk about, I didn't really think about as much. We all know the most common causes of facial paralysis. Obviously, for neurotologists, you manage CPA tumors, facial neuromas, trauma, Bell's palsy, and so forth. And so we'll kind of try to talk about many of these things. But before we kind of start with kind of, oh, do this technique, that technique, we need to understand what the patient, what type of peripheral facial paralysis the patient is presenting. This person on your left has a complete bilateral. She was born with Mobius syndrome. You see there's no activity. She's trying really hard to move her face, but can't. The young lady in the center has a complete unilateral. She had an acoustic neuroma, and you could see about 9 months earlier, there's no activity at all. She has a flaccid paralysis. And the last young lady is someone who has synkinesis, who has partial paralysis, has had a regeneration of her nerve, but an incomplete regeneration or an aberrant regeneration. So she can smile, she can move, but the face is frozen, it's locked in. So obviously, this individual is very different than the person with a complete unilateral paralysis or bilateral paralysis. Again, complete paralysis, someone who presents with complete paralysis, there is no activity at all. There is no facial muscle activity. And really, the management of patients like this is we need to increase power in that generator that we talked about. We have the brain, nerve, muscle, wherever we can, we have to try to increase power. Now, if the patient presents with paralysis or a new onset, a complete paralysis of less than 2 years, we can potentially revive their own muscles. So if we can do that, we want to do that. We want to try to use the patient's own ipsilateral facial nerve. And if not, the contralateral facial nerve can also produce spontaneity if possible. Again, this is a kind of a wiring process. And if the patient has long-standing paralysis, then we have to bring in new muscles, and we got to innervate those muscles with nerves, either from the patient's own facial nerve, contralateral facial nerve, or there are other cranial nerves that are available for us to innervate, or both. And so increasing power can and is the most important factor with complete paralysis. And I'll go through some examples. Again, this is a young lady who presented with an acoustic neuroma that had been treated somewhere else less than 2 years. And this patient has had complete and flaccid paralysis. And, this is one of the most important factors I think I would take from our literature that may not have been, as much in the, neurotology literature or other literature that's out there. Recent studies have shown that patients like this should be treated a little bit earlier than the 1 year mark because they're muscles are able to be revived better. So we're now starting to treat them at 9 months, because if they're not getting any tone back within 9 months, it's unlikely that they're going to have any manageable or reasonable smile. So for this person who had an acoustic neuroma, we can't access the nerve anywhere, but the nerve is accessible in the temporal bone and in the stylomastoid foramen. The muscles are still possible for us to revive the muscles because it's less than 2 years. So for this person, you have two options that are very, very good. Your main option is going to be utilizing the alternate cranial nerve to connect into the facial nerve that you have accessibility. That way, this alternate cranial nerve, and we'll talk about two options, can revive these muscles. This person ended up having a masseteric to facial nerve transfer, because the masseteric nerve gives us some opportunities because it's in close approximation to the facial nerve. Most patients, studies have shown, when we do a major smile, the masseter muscle actually gets activated, not because of the muscle, but because of its contractibility. So very, very easy to do through an outpatient procedure where you can connect the main trunk of the facial nerve to the masseteric nerve, as you can see here. And this is the type of result that you can get. Nice smile. The patient is biting down. It's not spontaneous. This is not spontaneous, but the patients can get a really, really nice, beautiful smile. And you can see nice teeth show. But look at her face. When she's not smiling, she is flaccid. The masseteric nerve does not give great tone. It gives very, very good, at least the technique that I utilize and I published on, gives a very, very good elevation, corner elevation, but it doesn't give great tone. So the hypoglossal nerve provides the most robust facial reinnervation of all cranial nerves because it gives really, really good tone. It gives a little bit more synkinesis and this overactivity, but this is a patient Dr. Slattery and I did a gazillion years ago with a facelift, brow lift, eyelid recon. She looks really, really good. She has a beautiful laugh line. This is another young baseball player that Dr. Slattery and I worked on together. Really nice tone, cheeks are up, and the patient obviously looks so much better. So that's kind of for a patient who presents with less than 2 years. And I'll come up with some other ways of managing those patients as well in a few minutes. But patients who present with long-term, over 2 years, their muscles are not viable. We can't revive anything. There's no, the nerves are pretty much, we can't utilize the nerve, we can't utilize the muscle. But the contralateral facial nerve is active, has redundancy, and is accessible. So for someone like this, we can get a very, very long sural nerve graft connected to the contralateral zygomatic branch of the facial nerve that has redundancy, and this is in that young girl. Transfer that to the paralyzed side. 6 months later, 9 months later, once that cross face nerve graft has been activated, that nerve graft is in just under the skin. It's not connected to anything. We can bring in a gracilis muscle. So we have to replace. We're missing muscle. We got to replace muscle. Bring in a gracilis muscle. And there are so many technical little nuances. We can bring in a dual paddle muscle, like in this case, or a single paddle, like in this case. Connect that cross-face nerve graft to the nerve, to the gracilis, and you can get reasonable spontaneous results for patients that can be life-changing and really, really beautiful. Now, you look at the laugh line, not as good Getting dental show is a little bit harder. Spontaneously, there's a little bit of delay in time, but you can get really beautiful results. Again, not perfect, but really nice results. This is like a 10-year follow-up on a young lady who had a gracilis flap as a result of a previous facial paralysis due to actually back keys. She had had a mastoidectomy that had resulted in a complete paralysis. Now, how about doing these techniques for older patients, for patients that, you know, typically walk into our office? It's still very, for a long time, everyone said, oh, you know, maximum age 40, 45. We're doing this in octogenarians. And again, this lady had an acoustic neuroma and that had been treated in New York and had paralysis. And we did, in the first stage, cross-face nerve graft. In the second stage, we did a gracilis flap, but I utilized two nerves, both the cross-face and the masseteric nerve, dual innervation to give a little bit more power. And you could see reasonable outcome, nice laugh line. She had been paralyzed for a long time. So she wasn't a candidate for 12-7, 5-7, all of those factors. So she got a really, really nice result. Now, sometimes we can combine these techniques. Like this is a patient who was from Florida, had a temporal bone fracture in an accident. So her nerve had been, you know, we didn't have access to it. She had come in about a year after that accident. And so her muscles are viable. So what I did for her in the first stage, you can combine a masseteric facial nerve transfer and a cross-face nerve graft, or a hypoglossal facial nerve transfer and a cross-face nerve graft. And Bill and I have been doing these really, really routinely recently, which is really amazing and fun. And then come back for the second stage and connect the gracilis to the masseteric, to the cross-face nerve graft. So this gives us a double function. One is the patient's masseteric or hypoglossal nerve will give the patient tone, and the native muscles get regenerated, and the cross-face nerve graft will give them spontaneity. And you could see there's really nice, beautiful results. And these are some examples of other patients that get really nice natural results. Now, for patients who we do not have access to the contralateral facial nerve because they have Mobius, they have bilateral congenital paralysis and muscles are not viable. And this is something that for a long time, basically the standard treatment was doing gracilis to the masseteric nerve. Then I started noticing, hey, sometimes we can actually elicit some activity in their platysma and in their DAO. Why not utilize these nerves? And so this is what I did for this young boy. We did a bilateral gracilis flap and we connected the nerve. I found these branches, really like multiple little tiny branches of facial nerve that were going into just his platysma. His platysma was active and so forth. And this is kind of the result that we were able to get. Really nice. This is natural, spontaneous. He's not biting down or anything like that. So this is like the first of its kind where we can, with Mobius syndrome, again, when we think about this native neuromuscular pathway, then we can really get fantastic results. Now, sometimes we'll see Mobius patients that I cannot elicit that platysma. So we have a couple of options. One is we can do the gracilis, bilateral gracilis, and connect it to the masseteric nerve. Or in this case, this is a patient that I saw. We've started a facial nerve, pro bono facial nerve clinic in Ecuador through Global Smile Foundation, which is this really amazing foundation. And so doing a bilateral gracilis on her would be, I've done a gracilis flap, but it would be really, really difficult and challenging. So what we did was, again, no access to any nerve muscles. This patient has none of it viable, but we can utilize the temporalis muscle and the temporalis tendon to mobilize the face. Patient, again, same thing as the masseteric nerve, can bite down. And we can get reasonable smile, and we reposition some of the buccal fat pad. You could see aesthetically she looks better and functionally she looks better. Again, with nice teeth, show really life-changing for her. Now, so although all of these results, obviously, I think are really, really great, especially compared to some of the stuff that, we were doing many, many years ago, most of the techniques still do not achieve all the components of a natural smile. They have obviously better symmetry, but the excursion of the oral commissure may not be perfect. We saw some of the laugh lines that were good, but there's some asymmetry. Teeth show is really hard to get. The symmetrical timing, even when we get spontaneity with a cross-face nerve graft, it's still not symmetrical timing. There's a delay in that. And so all of them have been really, really great, but still less than ideal. And furthermore, the majority of patients seeking treatment don't have flaccid paralysis. They present with synkinesis because the number one cause of facial paralysis is Bell's palsy. And Bell's palsy, as we all know, originally we thought 10%, but I would say probably a higher percentage don't have complete recovery. So should we manage someone with synkinesis or partial paralysis similar to all of these lovely surgeries that I just outlined that we've, improved on for facial flaccid paralysis? So synkinesis is basically we don't know exactly what is happening, but anytime the nerve has not been completely transected and the nerve has an opportunity to regenerate either from Bell's palsy, inflammation, infection, injury, repair, it can lead to synkinesis. And basically, what happens is when we have correct nerve regeneration and someone is trying to smile, the zygomaticus muscles, the levator muscles, the DLI gets activated. You get some minor activation of the orbic, you get some minor activation of the platysma and the DAO, but it's mainly really focused on this. But when we have aberrant nerve regeneration, not only do the correct muscles get activated, but we get overactivity of the non-relevant muscles. So as a result, a patient with synkinesis ends up having this frozen smile. The corner comes down, the upper lip comes down instead of up, the lower lip stays up instead of down, the eyes over narrow, the forehead doesn't move. And so if we split screen the individual, it's completely a different process between the two sides. So current surgical, what we were taught was, okay, synkinesis, maybe do a little PT, a little Botox. Really, patients walk in, oh, great, your nerves regenerated. But these patients are not happy. They feel like they're paralyzed. It's a different paralysis. So for a long time, we did either nothing, or about a decade or so ago, we were like, oh, we have all these cool surgeries. We're doing gracilis and the temporalis tendon transfers and the Masseteric transfers that are increasing power. So we were doing those. And of course, they were giving good results, but the patients had unnatural laugh lines. They had full muscles, cheeks that were a little bit larger. So the results weren't really satisfying. And in a patient like this, obviously, powering up is fantastic, but for a patient like this, it may not be necessary. And this is kind of where about 9-10 years ago, I started thinking, and this is again, with the help of, collaboration with Bill and Jackie Deals and others, all the time we're talking about, okay, what can we do? So what I realized is synkinesis gives us a very unique opportunity, because the patients don't have true muscle paralysis. They have innervated smile muscles. It's just this counterbalance of counterproductive and overactive muscles that are not coordinated. And we have access to the patient's own ipsilateral peripheral facial nerve branches, and they're present and they're accessible. And what's happening is basically this overactivity of muscles that we kind of don't want and don't really need, right? We don't need to show frowning to people. That's not, an emotion that's very important. So if we can reduce but not completely eliminate the activity of the DAO, the depressor angulioris, the platysma, the orbicularis, the mentalis, and the buccinator, then we can potentially, while preserving the elevators and the depressor labia inferioris, we can potentially enhance the muscle mechanism. So this procedure that I'm going to talk about now, I termed the modified selective neurectomy. It's now been published multiple peer-reviewed journals with, very, very objective data and so forth. I'll talk about them in a minute. But basically, it's an outpatient procedure. We use a facelift incision, deep plane incision. I go and dissect out multiple facial nerve branches, all the way from the frontal, all the way to the cervical. Like yesterday, I think my fellow is on with us. Yesterday, we dissected about 20 nerves going into the various muscles, multiple different nerves. And we selectively denervate the branches to the platysma, DAO, buccinator, mentalis, and just a slight amount of orbicularis oculi. And now we're about to publish this, kind of reducing the nerve to the corrugators, which can help with brow movement as well. And again, we preserve all the neural input to the key smile muscles, the orbicularis oculi, both and orbicularis and the DLI, so we can obtain a full denture smile. And this is an intraoperative kind of, you see all those vessel loops around nerves. Like this is a DLI we're going to save. And these are kind of the tagged nerves, and whatever nerve that we deemed not necessary, we'll go ahead and actually cut. And as you could see here, we take a segment of nerve, we put a hemoclip and cut out a segment. This is one particular nerve that we did. And these are some examples. And this is a person who presented with very significant synkinesis as a result of Bell's palsy. And by the way, this technique is very useful for patients who've had acoustic neuromas. Their nerve was temporarily out, they regenerate, and they have some persistent synkinesis. Same with temporal bone fracture. The young lady we did yesterday had a motor vehicle accident with temporal bone fracture that wasn't treated, and patient ended up developing synkinesis. But this patient had Bell's palsy, and you could see she has less teeth show, less upper dental show, only to maybe the incisor on the right. The lower lip is up. You would think that this is a paralysis. We actually don't think this is DLI paralysis. This is overactivity of the mentalis. You see the corner of the mouth going down. You see the eyes are narrowed. And this is her 1 week post-op. And this, we've seen our results basically, and we looked at our long-term results over a year, but look at 1 week, she's about to fly back home. Nice dental show, upper and lower. You see the lower lip is working better. So we coined this lower lip dysfunction, synkinetic unilateral lower lip dysfunction or palsy, because it's very different than other types of lower lip palsy. And you could see her face is more symmetrical. We also did a facelift for her. at the same time. And this is her video, and videos are really important. This is spontaneous, natural. She's not like, we just ask her, give us the biggest smile you can give. This is another person who has this synkinetic unilateral lower lip palsy. Her oral commissure is moving up well, but her lower lip is so high because of the overactivity of the mentalis, it's covering the upper teeth. And this is her after we did this modified selective neurectomy, and you could see her video and look at the lower lip improvement. This is another young lady who we did both the modified selective neurectomy on the right side and a touch of Botox in this left levator labial equinasi and some periorbital, and you can see it just looks so much improved. This is another person who had long standing synkinesis from gunshot wound to her temporal bone over 25 years. And this is her smile post-op. You could see the dental shows significantly improved. Her lower lip is moving down better. This is another person who you could see her smile before and after. Look at the improvement in dental show, both the upper and lower. Laugh lines are more even. Corner of the mouth is moving up. This is actually, you'll see the after is that lady that I showed at the very beginning talking about a natural smile. Her eyes are still a little narrowed. We can utilize Botox, but you can see just her smile is so much better. Platysma overactivity is gone. Some additional improvements. And this is someone that I haven't published on yet, but what we did was, this is a congenital case. And what I did for her was, we actually did a cross-face nerve graft in the first stage, because I thought for sure I'm gonna need to do a gracilis flap on her. But in the second stage, she had basically activity. As you could see, the corner of the mouth was moving down, and she had some remnant muscle that may have been risorius. We don't know exactly what it was. So I connected the cross-face nerve graft to that muscle and completely denervated all the muscles that were going into the DAO, all the nerves that were going into the DAO and the mentalis. And we were able to get a really pretty result, again, without needing to do. So you can combine these selective neurectomy procedures with other techniques. So this procedure, I mean, to me, I think why I really, really love this operation is because it allows us to achieve a lot of the ideal smile factors that we've been talking about. More symmetrical supralateral excursion of oral commissure, we get better symmetry of the nasolabial fold, we get much better improvement in dental show, symmetrical timing, it's spontaneous, it's natural, it's the patient's own ipsilateral neuromuscular process. Now, in conversation, when people are talking or puckering their lips, this doesn't improve that, because that's the orbicularis oris, and that muscle is a singular muscle that's sphincteric, and whether you downgrade it or upgrade it, that's not going to be able to do better. So that's the biggest weakness, I think, of this technique. And again, I think this is one of the only, if not the only one, that really reanimation technique that really achieves the majority of the components of natural smile. And again, the entire neuromuscular pathway is preserved. Now, we initially published our data on over 60 patients that were evaluated by independent observers. We saw long-term statistical improvement in House-Brackman, E-FACE, and we're just about to publish our long-term results on patient-reported outcome measures with the Synkinesis assessment questionnaire and the FACE questionnaire. I still utilize Botox for periorbital and contralateral areas. The patients do need extensive neuromuscular retraining. The most common side effect is temporary oral incompetence, because the patients really feel like, oh my God, what just happened to me? That all resolves within a few weeks to months. And sometimes you see really immediate improvement within the first week, but typically we wait about a year. About 10 to 15% of patients get a significant improvement, but not as good as maybe the ones that I just showed you. And in those patients, I typically take them back about a year later, and I need to do maybe a few more nerves because weren't able to, capture all the nerves or identify all the nerves. There is a major learning curve with this, and it takes a long time to find the nerves, all these nerves, and also understand which ones you need to take and not take. But it's a really, for patients, it's a very quick recovery, outpatient procedure, and they go home right after surgery. So in summary, I think, again, we want to have various reanimation techniques in our armamentarium. And it really depends on the etiology, length of time from onset, and so forth. I do think there has been a paradigm shift in the treatment of patients with synkinesis, really downgrading signal rather than upgrading, kind of like, that's why we do Botox a lot in the neck and so forth. It's really reducing the overactivity. But unfortunately, Botox and other like physiotherapy and neuromuscular retraining just can't get us to show more teeth and move the corner of the mouth higher. So that is one of the reasons why the surgical approach is really, really important in these patients if they really obviously are seeking that. And it can really significantly improve their spontaneous and emotional dynamic smile. And as always, again, interdisciplinary discussions are really, really important to for us with facial nerve disorders. And obviously, neurotology, facial plastic surgery, rehab, otolaryngology, oculoplastic surgery, all very important to work together like we have over many years. So, and anyways, that's kind of the end of and these are my contact info, my email, direct email, and be more than happy to answer any questions if there are any.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.